So our topic today, what is a calcium score? First, a little bit about me. So I am Dr. Murphy. I am a cardiologist here in Westwood. I've been here since 1995 in the same location, which is fairly astonishing. And I do general consultative cardiology. So I am a non-invasive cardiologist. I don't do angiograms. I don't do heart surgery. I take care of the medical care of heart disease. So that's high blood pressure, cholesterol, heart attacks, heart rhythm problems, congestive heart failure, and such. So calcium score is something that we use as a tool each and every day, and that's going to be today's topic. Okay, here we go. All righty. So today we're going to start out with some definitions. What is calcium? What are coronary arteries? Atherosclerosis, the term plaque, both soft and hard, and what is a CT scan or a CAT scan? We're going to talk about who is a candidate for coronary CT calcium scores, and importantly, who is not a candidate. And we're going to also talk about what's called a heart disease risk calculator. That helps us to decide who should and should not have a calcium score. We're going to go over how a coronary calcium score is reported and what it means, and also how cardiologists use these tests to advise patients in terms of their prognosis and treatment. I have some examples of pictures of CT calcium scores later in the talk, and then just briefly we'll talk about what incidental calcification is, because that's important as well. So first, what is calcium? So on the periodic table that some of us may remember from school, it's the chemical element, atomic number 20, and it's a soft gray metal. Calcium is considered a metal. It's a mineral your body needs to build and maintain strong bones. And it also carries out many important functions in the body. Most of the calcium in the body is stored in the bones and teeth, which give them structure and hardness, but there is calcium in the bloodstream circulating around, and calcium can be deposited in other tissues other than the bones and teeth, such as the heart or coronary arteries, which is the basis of what we're going to be talking about today. And calcium is bright or well visualized on X-rays and CAT scans. And we are going to show some examples of that later and talk about what a CAT scan is and how a calcium score is produced. So first, what is a coronary artery? So we're going to go with some definitions here. A coronary artery is a blood vessel which supplies blood, oxygen, and nutrients to the heart muscle. So the heart is a pump. It pumps blood around the body, but it also requires a blood supply, which you can see here. So the left main coronary artery is a little branch that comes out of the aorta, which is this big blood vessel here, and the left main coronary artery immediately splits in two, and it produces the left anterior descending coronary artery, which is right here, and then the circumflex, which goes around the back. So when you look at a calcium score, you'll often see left main, left anterior descending, and left circumflex, and then also the right coronary artery, which is over here on the other side. So when you talk about people having bypass surgery, you may hear triple bypass. That usually means that you've got a bypass to the right coronary, the left anterior descending, and the circumflex. But people can have more than 3 arteries. All of the arteries have branches, which you can kind of see here in this picture. And so you can have 3 and 4 and even 5 bypasses. So just for definition's sake, a coronary artery is a blood vessel which supplies blood, oxygen, and nutrients to the heart muscle. So here we have a picture, and I put both an artery on top and a vein on the bottom because people often will get them confused. An artery takes blood away from the heart. That's how you remember it, artery away. And a vein takes blood back to the heart. So the arteries are what we're talking about here, and they have, the blood is in the middle in red. This little orange area here is called the intima or the endothelium. That's the inner part. The media, or the middle part, is this pink part, that's muscular. And the adventitia is the outside, which is like the bark of a tree. And when we talk about plaque, which we're going to talk about later, the plaque deposits underneath the intima or endothelium in the media, or the middle portion. That's where the plaque of the coronary artery deposits. And just for comparison, so the vein, which takes blood back to the heart, the blood in the artery is under pressure because it's when the heart pumps, it produces pressure that forces the blood out. And the vein is a lower pressure, so it doesn't have nearly as much muscle in it, and it's got a thinner wall, and it is not involved in the coronary artery calcium process that we're talking about. There are coronary veins as well, but usually we talk about the arteries when we talk about diseases that need treatment. So next definition is atherosclerosis. And what is a coronary artery soft plaque? So atherosclerosis is the process by which cholesterol deposits in an artery, which includes coronary arteries. And a soft plaque, which is the nasty kind, contains fatty substances, including cholesterol. And importantly, it may or may not obstruct blood flow. In other words, if you have plaque, cholesterol deposited in your heart arteries, you could have no symptoms at all and not know about it because it's not obstructing the flow of blood. It has to be more than 70% narrowed. You know, when we look back at this, you need to see only a small portion of the artery still open in order for there to be symptoms. You could have even 50% of the lumen or opening of the artery blocked and not have any symptoms with or without exercise. So we'll talk about that a bit more as well. So atherosclerosis is the process of cholesterol deposits, and they all start out, and we'll see a picture a little bit later, they start out small and can get bigger over time with these fatty substances. And inside of that fatty plaque is what's called inflammation. And inflammation is defined as the body's immune system response to an irritant. So the fat in the wall of the artery is an irritant, and it produces inflammation. So it's present in soft plaques, and it increases the risk of a heart attack, which is the kind of colloquial term for myocardial infarction, which is the medical term. So as plaques age, they go from being soft to hard. As the inflammation heals, calcium is deposited in the coronary arteries. So the plaque transforms from a soft plaque into a hard plaque with time. So the hard plaques, interestingly, are less likely to rupture or ulcerate, which is what causes that myocardial infarction, and are also less likely to cause myocardial infarctions. Calcified plaques are what we can see, what are visualized on the CT coronary calcium score. So we've got calcium, we've got arteries, we've got atherosclerosis, and now we've got soft plaques. And those soft plaques, as they age, transform from soft to hard as the inflammation heals. And that is what we can see on our CT coronary calcium score. So this picture here is a little bit busy, but it starts here at the top with your young, healthy artery, with your intima, media, and adventitia, those three layers. And you see here from the first decade, when you're a child, this is what your arteries look like. And then as time goes on, this is time here from the third decade into the fourth decade. I hope it doesn't happen to us, but with time, just about everybody will develop what are called fatty streaks, where cholesterol begins to be deposited in the heart wall. And then as time goes on, those plaques can get bigger, and then they eventually become an atheroma, which has a fatty core here of inflamed, nasty cholesterol and other substances. And then as time goes on, they can progress. And what we see at the bottom here, this is a heart attack. This is the cap or of the plaque, or the intima has ruptured, and this is a blood clot formed when the blood, which normally freely flows through here, comes in contact with the fat. A blood clot is formed, and that's what's called thrombosis, and that is a heart attack, a complicated plaque. So we hope we don't get here, and we're going to talk a little bit more about what kind of interventions are possible in this sort of cascade over time. These pictures are of actual specimens of plaques, and you can see the lumen is the opening. And in both of these pictures, the opening is wide open. You would not have any kind of symptoms from either of these plaques. This one is a smaller looking plaque with the fat or cholesterol in here, and here's the fibrous cap. that can rupture or ulcerate, allowing the blood within the lumen to contact the lipid-rich core and form a blood clot. And this is another, sort of another way of looking at it with different stains in this slide, but this is the similar kind of a plaque. You can see there's more kind of nasty fat cells here, and here you can appreciate how thin the cap is, and the thinner this cap is, the more likely it is to rupture and allow the blood to contact the fat in the artery lining. So next we move on to coronary calcium score, the reason for this talk, and how do we make a decision about who should get one. So first we talk about atherosclerotic cardiovascular disease, which is abbreviated ASCVD. And we cardiologists and internists too do these statistical predictions. We use these risk calculators, and they are based on the data of thousands of people over many decades. And they give us an ability to predict what a person's individual risk is, which helps us to decide who should have a coronary CT calcium score. There are other kind of population studies that we'll talk about a little later that also help to determine which patients should have these. So the coronary artery calcification scores are used together with these risk scores and help to decide what to do next for a person. So we'll talk about that as well. So how does detecting coronary artery calcified plaque affect my health? And this is really important. It's about a person with no symptoms. In an asymptomatic person, if we detect coronary artery calcification, that means that person's risk, even though they feel fine, has increased of having cardiovascular events, including myocardial infarction, heart attack, stroke, and death. So that identifying coronary artery calcification in an asymptomatic person gives the opportunity to intervene before an event occurs. So it's important that if you have a positive coronary calcium score, you consider it to be a good thing in a way. You wish your score was 0, but if you do have calcification, it gives you the opportunity to make significant lifestyle and medical changes to improve your life and reduce your risk. So how do we select the patients that are candidates for coronary CT calcium score? So oftentimes we start with one of these risk stratification and scores, which we do. We all have them on our phones, and you plug in a person's age, gender, blood pressure, their total cholesterol and their HDL cholesterol, and whether or not they're on blood pressure medications, and then out pops a score, and then we can help advise people what to do next based on that score. So a low risk score is less than 5%. And the way these scores are reported is a 10-year atherosclerotic cardiovascular disease risk, meaning what's an individual's risk over the next 10 years of having a heart attack or a stroke. And so low risk is less than 5. Borderline elevated is between 5 and 7.4. Intermediate is between 7.5 and 10. High is greater than 10, and very high is greater than 20. And we do see people routinely have scores in all of these ranges when we see people in cardiology consultation, and it helps us to advise people who should have a coronary artery calcium score. So the people who are a candidate include, and this is what the data show in the current recommendations, asymptomatic adults, again, important, greater than or equal to 40 years of age at intermediate to high risk. So that's that 7.5% to less than 20% 10-year risk calculation using that American College of Cardiology, American Heart Association risk calculator. And then importantly, very importantly, actually, if the decision to treat with statin medication has already been made, a coronary artery calcium score is not recommended. So if you have a total cholesterol level of a certain amount, or a medical background or a history such that cholesterol medicine has already been given, you don't need to expose yourself to the admittedly low amount of radiation that a CT scan confers. It's not going to change your management. We don't order a test if it isn't going to change the management of a person. So other candidates for these coronary calcium screenings include asymptomatic individuals in the borderline range, so that 5 to 7.5% range, particularly if you have risk-enhancing factors. So we'll talk about those, but coronary CT calcium score is reasonable in these borderline calculation range patients who have risk-enhancing factors. And so that means that when you talk about conventional risk factors of age, male gender, high blood pressure, high cholesterol, smoking, and diabetes, these are clinical or historical facts about an individual that increases their risk and therefore helps us to decide, oh, you're kind of on the borderline with risk. We may not necessarily want to treat you with cholesterol-lowering medicine, but let's do the CT calcium score because that'll give us extra information to help treat you. So a family history of ischemic heart disease, premature menopause and preeclampsia, chronic inflammatory conditions like psoriatic arthritis or rheumatoid arthritis, and South Asian ethnicity are all considered risk-enhancing factors that help to decide who is a candidate for coronary CT calcium score if they have no symptoms and want to optimize their risk. So importantly, who should not receive a coronary CT calcium score? So a patient who's at low risk, less than 5%, or very high, greater than or equal to 20% 10-year risk, because those people on the low risk are unlikely to be treated with medication, and on the high risk should be treated with medication. In other words, in addition to a healthy lifestyle, they meet criteria for using cholesterol-lowering medications to reduce their risk, even if they've never had a heart attack or any kind of an event. So high-risk patients should be treated regardless of the result of a CT scan. So we don't do a test if it's not going to change our management. So those people should not be getting a CT calcium score. And importantly, patients with symptoms that could be consistent with heart artery blockages should not receive a coronary CT calcium score. Different cardiac testing is recommended in that situation. So it's not a diagnostic test, CT calcium score, it's a screening test. And we're going to talk about that as well. But let's back up a second and say, what is a CT scan? So a CT stands for computed tomography, and it's a diagnostic imaging procedure that uses X-rays and computer technology to create images of the inside of the body. So it's a fancy X-ray that uses a computer to reconstruct the images on the inside of the body. And coronary CT scans specifically evaluate the heart arteries. So here's a CT scanner. A lot of people ask, what's it like? They're a little claustrophobic. They're concerned about if they're going to be claustrophobic with this. So the patient is placed lying down on this platform, which moves, and I call this the big white donut. It is a because I think they're all white. It is not enclosed. It's open on the other end. So you go through this, and it is a fairly quick test, and it doesn't have that same claustrophobic feeling that, for example, an MRI might have, and it is much, much, much faster than an MRI. And there are two basic types of coronary CT scans. The one we're talking about today, the CT coronary calcium score, does not require an intravenous. It detects calcium deposits in heart arteries to diagnose atherosclerosis. Now we know all of those definitions, and it generates a calcium score that we're going to talk about a little later. And once again, it's a screening test. A screening test detects asymptomatic disease. Someone who has no symptoms of heart disease has a CT calcium score to help define their risk and help manage and reduce their risk going forward. And that's in contrast to a CT coronary angiogram, which is a diagnostic test. These days, it's used to detect symptomatic disease. So someone, for example, who has chest pain or exertional shortness of breath would get a CT angiogram to look and see if their symptom is related to a blockage. So this CT scan requires an intravenous contrast injection. It also is typically reported with a calcium score. They get that information during this test too, but this test looks at the heart arteries in more detail. So it can show if there is plaque, hard or soft, and what percentage of blockage is present, if it is present. And again, it's not a screening test. We don't do the CT coronary angiograms in asymptomatic people these days. This may change with time, but this is the current recommendation. So now we get to what is a calcium score. So after you have your score, after you have your scan, the computer does an analysis of the images that are taken. And so if the computer sees calcium, it generates a report, of course, interpreted by a radiologist or cardiologist about the location of plaques, and it also gives a numerical score. So this CT calcium score is based on an analysis of the area or size of any visualized plaque and the density or quantity of the calcium deposits in the media and the wall of the heart artery. So calcium score is typically reported using the scale here, and these are numbers to try and remember, and again they'll be in the recording. But a score of 0 is good news, and there are different reporting scales, but the Agatston scale is typically the one that we see most. Agatston is the name of the doctor who developed the scoring system, just as a fun fact. So if you have a score of 0, that means you have no identifiable disease. There's no calcium in your heart arteries that they can see. A score of 1 to 99 means mild disease, but there is disease visualized. A score of 100 to 399 is moderate disease, and a score greater than or equal to 400 Agatston units is severe disease. So the coronary CT calcium score refers to the amount of calcium visualized in the heart arteries. And my line is, it's a test you'd like to get a 0 on, because a score of 0, as we will learn, has a good prognostic connotation. So the analysis, many of the reports, different institutions report these things in different ways, but many of them report these MESA scores, so multi-ethnic study of atherosclerosis. And this, again, is a statistical assessment, and it compares an individual's coronary artery calcium score to patients of similar age, gender, and ethnicity. And it's important to interpret the score not just as an absolute number, which is important, but also to give additional information specific to the patient's background. And this score is used in people aged 45 to 84 who do not have diabetes or known cardiovascular disease. Again, this test is validated, this specific MESA score is validated in this particular patient population. And there can be people outside of this age range who have the score performed, but the MESA analysis is typically done at this age. And again, many of these CT coronary calcium scores will include that information. And this data, again, can help guide treatment decisions, including lifestyle measures, which are always important, and medication where indicated. So in terms of a calcium score, there is what's called an absolute number. That's 0, which is nice. There's less than 100. There's greater than 400. So there are all these different numbers that we get, and it is typically reported per coronary artery, so individual numbers in each location, and then a total score, and then we'll give you a percentile. So the importance of the score itself is that in a younger person, for example, with a coronary calcium score of 40, 40 is less than 100, so there is a relatively low short-term risk of having an event, but it's a higher lifetime risk if the score places them in the category of greater than 75th percentile for age and gender. So there's the absolute number, less than 100 we see here, but if you're greater than 75th percentile, you're talking about lifetime risk, and that's where the intervention is targeted. Patients who have a coronary artery calcium score greater than 400 are at higher risk, regardless of the time horizon. So they've got a higher short-term risk of having a cardiac event and a higher lifetime risk as well. And the degree of aggression for treatment is, again, shared decision-making with the patient, of course, is a greater degree of aggression if you have a higher score. So in both males and females, the presence of coronary artery calcification detected by CT is highly sensitive for the presence of atherosclerosis. So if you have any visualized plaque on a coronary CT scan, that means you have coronary in your heart arteries. And importantly, you also have those soft plaques. The coronary artery CT score does not see those soft plaques, those ones I described as nasty, with the fat and the inflammation and the thin caps that can go on to cause heart attacks. So it is important to remember that although a score of 0 carries a good prognostic sign, that there are limitations to the test, which we'll get into a little bit later. But again, if you have any coronary calcium, you have documented plaque. So again, a coronary calcium score of 0 is what's called a strong negative risk factor. That means if your score is 0, your cardiovascular risk is reduced when compared with people with a non-zero score. So compared with a person with a score of 0, increased cardiovascular risk was demonstrated for coronary artery calcium scores greater than 100. But again, if you're less than 100, it means yes, you have plaque, and some sort of intervention is recommended as well. So we counsel all patients in terms of recommendations to make therapeutic lifestyle changes. So healthy diet, the one that's reported and studied and really well documented is the plant-based or Mediterranean diet. And one of the great things about the Mediterranean diet is that it is tasty. It's Italian food, Greek food, Middle Eastern food. It uses healthy fats like olive oil. It incorporates fish twice a week where possible, tries to minimize carbohydrates and minimize processed foods. So it really is, and it's pretty easy to follow without feeling like you're deprived. Of course, smoking cessation is important. Regular exercise, at least 150 minutes a week of moderate cardiovascular exercise a week with 2 to 3 sessions per week of resistance training. That improves balance and muscle strength, and metabolically is beneficial in terms of regulating your caloric use. Stress management is an important and not often discussed aspect of general health, whether it's listening to music, looking out the window at the birds, mindfulness training, yoga, breathing, all of these things. Identifying stress in your life and working to manage it is important. And of course, good sleep hygiene. We're learning more and more about the fact that burning the candle at both ends isn't a good idea health-wise, and working on going to sleep at the same time and being more regulated in your sleep is a good plan. One important aspect is that we do not recommend repeating coronary artery calcium scans to assess the efficacy of lifestyle changes. So if, let's say, a person has a score of 40 and they're interested to see if the score goes up after they are exercising, it's not recommended because the calcium never goes away, importantly, never goes away. The plaque doesn't really regress. I mean, they may shrink by a teeny tiny amount that's not detectable with the conventional evaluations. And so it's not the kind of a thing where I'm going to look again to see how well I'm doing. And in fact, as time goes on, coronary artery calcium score typically increases because of that healing process. You take a nasty, fatty, soft plaque and calm it down and make it a calcified plaque, your calcium score goes up with time, and it's not a failure of treatment. In fact, it's expected as part of the healing process. So again, if your coronary artery calcium score is greater than equal to 100 or the 75th percentile for age, gender, and ethnicity, statin therapy, which is cholesterol-lowering medication, is recommended if your LDL or bad cholesterol is between 100 and 190. And many, many, many people say, can I just work on my lifestyle and other such things? And I have to say that, of course, you want to work on your lifestyle, but if you have documented plaque, the current recommendation is to calm your plaque down with statin therapy, and finding one that you tolerate in collaboration with your doctor is important. Many cardiologists these days would consider statin therapy in patients with any measurable coronary artery calcification. Even if your score is less than 100, your risk of a cardiovascular event is increased over the course of your lifetime. So it may be relatively low in the short term, but it's increased, and statins are the best treatment that we have to optimize that. There's also so much discussion about aspirin, 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 aspirin. So many of my patients have stopped it or read on the, on the internet or heard on the news, nobody should be taking it. So if you have atherosclerosis, you typically are a candidate to take a low-dose aspirin. And the recent studies say that the low-dose aspirin has clinical benefit in patients under the age of 70 who have a calcium score greater than 100. Now, this isn't a blanket statement for everyone, but when you're talking about how calcium scores affect the use of aspirin, this is the data. If your score is over 100 and you're under the age of 70, baby aspirin a day is reasonable to take. So additionally, now we've got more subtle divisions of the numbers. So if your coronary calcium score is between 1 and 99, or less than the 70th percentile for age, gender, and race, still you are a candidate to consider statin therapy after discussion. And so that is one important aspect of things. So the data may be less definitive, but many people will elect to take cholesterol-lowering medication once they discover they have plaque in their heart arteries. But importantly, aspirin use based on current data in this patient cohort is not recommended. So if your score is less than 100, you might be considered a candidate for statins, but we don't recommend aspirin. And you don't have to remember all this, but it is important to realize the subtleties. So coronary artery calcium score of 0. Remember, this is a test you'd love to get a 0 on. So routine use of cholesterol-lowering statin therapy in patients with coronary artery calcium score of 0 is not typically recommended for up to 5 years. So this is a case in which you might consider repeating the test after 5 years. If your score is 0 and you don't elect to take medication in collaboration with your doctor, you don't have other reasons to do so, repeating the risk stratification should be performed. But unless there are other compelling risk factors, including diabetes, active cigarette smoking, hypertension, or a family history of premature coronary disease. And that's where the conversation comes in. Some people absolutely don't want to take medicines. Some people are so anxious about their family history that they'd like to take something, even though they're reassured by their 0 score. So there's no one size fits all for this advice. But again, aspirin therapy is typically not used for primary prevention, which means preventing a heart attack before it happens, with a coronary artery calcium score of 0. So in terms of follow-up, once again, if you have a 0 score at baseline, you can use the risk calculator that we talked about earlier to help determine when or if the scan should be repeated. So if your score is 0 and your risk is low, 5 to 7 years. If you're in that intermediate range in the 5 to 10%, and you're not on statin therapy, consider repeat scanning in 3 to 5 years. And in patients with diabetes, consider repeating the scan in 3 years. And again, many cardiologists treat adult diabetics with statin therapy regardless of coronary CT calcium score. Diabetes is considered to be a coronary artery disease equivalent. In other words, that people with diabetes have a similar cardiovascular risk to a person who has had a cardiac event such as a heart attack. And so aggressive treatment in many cases are indicated, depending on age and other factors. So following up. So again, serial or repeat calcium scoring is not recommended in patients with calcium scores greater than 0, particularly if it's greater than 100, as repeating that test will not alter your management. And repeat coronary artery calcium score is not recommended to assess the efficacy of cholesterol-lowering therapy. As we said, the calcium score is likely to increase with time as cholesterol-lowering statin therapy helps to accelerate that healing process. Within 2 weeks of starting a statin, the plaque in your body has already begun to reduce its inflammation and reduce the risk of rupturing and causing you an acute coronary event. Studies suggest, again, statins may increase the calcified content of individual plaques while reducing non-calcified plaque volume. They help heal the inflammation in soft plaque, converting them to hard plaques, which are less vulnerable to plaque rupture or myocardial infarction. So that, I know we've said it several times, but it's very, very important. So some special considerations in female patients, and this is important because females have less coronary artery calcification compared with males of similar age and risk factor burden. We've talked about those risk factors earlier. But the prognostic value of coronary artery calcium is equal regardless of gender. So if you have calcium, and men and women have similar prognostic scores. So females generally have a lower 10-year risk calculation using the risk calculator that we talked about earlier, the American College of Cardiology, American Heart Association. And therefore, those risk modifying factors that we talked about earlier are important in deciding whether to perform a CT coronary calcium score in a person with a relatively low risk calculation. And there is a different type of risk calculator called the Reynolds score, which has improved predictive value in women. And it incorporates a blood test called high sensitivity C-reactive protein, which is a measure of inflammation in its predictive model. So, we have to kind of take the individual into account when we're making these recommendations. So, guidance on the timing of first calcium score with and without diabetes. So important, males screen younger than females. So in diabetics first, we start younger still. So males with diabetes should be screened for the first time, age 35 to 38, which is very young, but very important because making those interventions early makes such a difference. Females with diabetes, aged 49 to 52, and men without diabetes, age 41 to 44. Again, timing of the first calcium score. And females without diabetes, 56 to 60. And just a little kind of parenthetical here, I order these tests all the time, and patients often hear, oh, my insurance company won't pay, even though we have a risk factor or other such things. And sometimes people wind up paying out of pocket. And I know Valley often accommodates people making the appointment to have the scan on their own, even without a prescription from a doctor. But you'd like to think that the insurance companies would pay for this very important screening test. So importantly, as I mentioned earlier, CT calcium scoring is not perfect, and up to 10% of patients who have coronary artery calcium scores of 0 have non-calcified plaque in their heart arteries. And that should come as no surprise. In a younger person whose plaque hasn't been there long, in whom healing has not yet occurred and calcium hasn't deposited, there is still a plaque. And non-calcified plaques, once again, are the most common cause of heart attacks and myocardial infarctions. So it's important to remember, even if you've had a coronary CT calcium score of 0, if you develop new symptoms or a change in your exercise tolerance or anything that concerns you, you should present for an evaluation. So I'm going to show you some pictures now of a coronary CT calcium score. This one is a score of 0, I believe. I don't see my own caption, but all right. Okay, all right. So I'm going to play it for you. So just so you know, so this here is the spine. This is a vertebral body, and the white is calcium. And so, and this is a rib over here and over here, and this is the sternum. This over here is one of the branches of the breathing tube or trachea, and they also have calcium in their walls. So what we're looking at here are going to be, and it's going to be a moving image. We're going to scan through the blood vessels in the heart. This is the aorta, and we're going to look for calcium deposits in the heart arteries. And this person has a score of 0, and you won't see any in the heart arteries. Here we go. Again, any calcium you see is either in bone or in the trachea or the branches of the trachea, which are the respiratory structures. And this gray is we're scanning through is the heart. Now we're down below the heart, and this is the liver, and this is the intestine. So that's a score of 0. That's a good answer. So here, the next one is a score of 102. Remember, we talked about 100 being a cutoff for an increased risk. So here, the reports often look like this. Your total score is 102. Your score of 102 places you in the 75th percentile rank. That's the other number that we look at. And this particular person has just a score. We'll look at this column, a score of 43 in the left anterior descending artery, a score of 2 in the circumflex, a score of 57 in the right coronary. So all three of the branches of the heart arteries for a total of 102. So again, we're going to look here. There's calcium here in the sternum, in the rib, in the vertebral body, and in this person, we're going to see vascular calcium. So when we look at it moving through, we're going to see little flecks of calcium in the heart arteries. That is where the score comes from. And so you can see those in this scan. So that's your score of 0 and your score of 102. And I'm sure you've all guessed that the next one is someone with even more. So this person has a score of 7,110 in the 90th percentile rank. So this person has calcium in the left main artery, that branch that immediately divides into the left anterior descending and the circumflex. Each of these individual scores, 1,768 in the LAD, 1,537 in the circumflex, the right coronary artery. So it's got a lot. And you will, now we're experts. So here's the calcium in the sternum. You're going to be looking here at the vascular structures, and it will be very clear that there is a lot. So here, all of that calcium that we see, all of those heart arteries mean that this person has a higher score, and this scan would lead to aggressive risk factor. So finally, just one final thing. Sometimes there's what's called incidental calcium. So coronary artery calcification is sometimes detected on CT scans that are obtained for other reasons, commonly the lung cancer screening CAT scans and smokers who have these tests. So the radiologist doesn't usually give a score. They say the coronary artery calcium is present, and they describe it. And they will often say whether it's present, how severe it is, and how extensive. But sometimes it's just present or absence. But it's important to know that any coronary artery calcification seen on a scan performed for another reason should be treated the same way as for someone with a non-zero intentional coronary artery calcium score. That's a person who is having the test specifically to look at their heart arteries. So we see people all the time who have CAT scans for various reasons, who have coronary artery calcification and are sent for cardiology consultation. We don't actually have to do another CAT scan. We already have the answer that some of it is present. We don't have the prognostic information in terms of the score or the percentile, but again, the presence is important. And then we do one of those risk calculators and help patients to see what treatment is recommended. And so that's incidental coronary artery calcification, which that question comes up a lot in my cardiology practice. And so that is everything. That's the story of a coronary CT calcium score. I just want you to know Dr. Alap Chokshi is one of our advanced cardiac imagers, and he gave me the picture of the CAT scanner and those coronary calcium images. Those are actual images from real patients. So thank you, everybody, for your attention.
Oh, thank you so much for that very interesting and comprehensive presentation, Dr. Murphy. Just a couple of questions. Somebody had mentioned, and I'm not sure if you answered this, forgive me if you have. Do you think the LDL particle test is useful to identify the lipid level?
So the LDL particle test gets a lot of press. So the classic cholesterol profile includes a total cholesterol, an HDL cholesterol, triglycerides, and the LDL cholesterol. And there are two different ways of arriving at LDL cholesterol. One is directly measured, and one is a calculation based on the total and the triglycerides. So those are the tried and true lipid panels, lipid profiles that we've been using for decades. And there are particle size and other additional tests that are sometimes done. They are amazing tools in cardiac research in order to try and help kind of fine-tune analysis of coronary disease. And there's something called LP little a or lipoprotein little a that is another test that is often done. And they can be used again, to help fine tune things. I don't typically order them. Many people come to me with them, having had them done elsewhere. I don't typically order them right off the bat. I use the conventional lipid panel in combination with these risk calculators to help to decide what to do. In young people with a positive family history and other such things, getting a particle size information can be helpful in guiding the treatment, because when you're talking about putting someone, in their 30s or 40s on cholesterol lowering medication, you like to have as much information as you can. But the fact of the matter is, most of the time, a conventional lipid panel gives enough information to help to make those decisions.
Thank you. Another question, have you heard of a treatment called, trodosquamine? Have you heard of that?
I haven't, not
Trodusquam. Okay. And let's see, I do have another question here. Someone asked about they're having a parathyroid surgery next week, and she did show a calcium score. My blood test showed the calcium at 10.4. Does that affect arteries?
Right. So that's a great question. So a calcium of 10.4 is a blood test. So it's not a calcium score on a CAT scan, but 10.4 is a mildly elevated serum calcium level, and that's often associated with parathyroid disease, parathyroid adenomas, for an example, a little tumor in the parathyroid gland that overproduces the hormone which regulates calcium. So there is a lot of discussion about whether an elevated serum calcium accelerates the deposits of calcium in areas in the body where they don't belong. But the fact of the matter is, the calcium in the coronary arteries only goes into the plaque as part of the healing process. So if you have calcium in your heart arteries, regardless of your serum calcium, it means that you have plaque, both soft and hard, but you can see the hard ones on the CAT scan. So that's an important piece of information.
Right. Someone asked if you could address the relationship between low calcium score and high LDL, if you could just sort of repeat that. Yeah.
If a person has an LDL cholesterol over 190, that's what's called familial range hyperlipidemia. There are certain inherited tendencies to high cholesterol, and an LDL greater than 190 is a marker for that. So typically, if you have an LDL cholesterol greater than 190 on two separate occasions, then you are considered a candidate for cholesterol lowering medication. And so typically, that's one of the situations in which you would not get a coronary CT calcium score. However, if you did and your score was 0, the recommendation, quite frankly, would still be the same, because you're trying to intervene before you have a problem. And again, cardiovascular disease is the #1 cause of death in this country. So if you have the opportunity to intervene on something, you can't change your genes, but you can change your cholesterol and therefore your tendency to deposit it in your heart arteries, then that is reasonable. So the LDL over 190 is considered a reason not to proceed with a CT calcium score. But if you needed more information to help and you wanted to avoid taking medication for, I wouldn't wait more than a year or two to repeat the scan in a person with that kind of a risk.
Just a twofold question. Is dietary calcium related to a calcium score? And do meds like Reclast or taking calcium impact your score?
That's another excellent question, because people have been prescribed calcium supplements as well as medications for osteoporosis for a very long time. And, I have always been a proponent of getting your body's nutrients from natural foods, because you're unlikely to overdo it. But in certain situations, calcium has been prescribed. And so we don't really know yet what the effect of supplemental calcium is. However, you have to always weigh risks and benefits. We know that osteoporosis confers an increased risk of fracture and other morbidities. And so taking medications to try and help treat that metabolic bone disease understanding that there may be an increased risk of calcium deposits elsewhere is important. But remember, the calcium doesn't go where there isn't plaque. So that is important in this specific instance.
Someone just is asking about a nuclear stress test. Would that be used to further determine the risk factor after a high calcium score? Would that be something?
Right. So that's a good question. So when you have a score over 100, over 400, and remember that person that we showed 1,700 plus. So if you have a score over 400, then you talk about short-term risk and lifetime risk. Your short-term risk of having a cardiac event is higher. So even in the absence of symptoms, many cardiologists will have a person do a stress test. But you wouldn't necessarily need a nuclear stress test. If you have a normal EKG, a normal electrocardiogram, and then you put someone on a treadmill and have them walk for the exercise treadmill protocol, if that test is normal, that means even though you've got lots of plaques, it's not blocking blood flow. I had shown you those plaques earlier where the lumen or the opening was big and the blood is flowing through fine. And so you wouldn't have any symptoms at all. And so if you have a high calcium score and you have no symptoms, then a regular treadmill stress test and your EKG is normal. A regular treadmill stress test is likely to give you the answer you need in terms of whether you require additional intervention. So the lifestyle, the aspirin, the cholesterol lowering medicine, and anything more based on a regular treadmill stress test. You wouldn't necessarily need a nuclear test, which is reserved for people either who have an abnormal EKG that's not interpretable for looking for blockages, or who have an abnormal exercise treadmill test at a very high level of activity, for example, and you want to get additional information about any areas of reduced blood flow.
Okay, just a couple more questions.
Sure.
And then we'll be done. Somebody was just saying that two brothers very recently, fairly young, 58, 63, had strokes in the past month. Very concerned about their own risk in this area. And one had calcium in a carotid artery. Is that something? Can you talk about that or just give some insight into that issue?
Well, all arteries or blood vessels in the body can develop atherosclerosis. So today's talk was specifically about coronary artery atherosclerosis, but the carotid arteries, which go to the brain, can also go through the same process of plaque formation with fatty streaks, soft plaque, and then calcified plaque. So oftentimes the calcium is seen in the arteries to the brain when evaluating someone who has had a stroke. So the treatment, cholesterol lowering medication, and typically aspirin or something like it, are very, very commonly given. But there's a lot of discussion about, and this isn't my area of expertise, but who should have carotid artery screening. There's discussion about what's called intimal medial thickness and increased cardiac risk, and there are a lot of these companies that go around and do these kind of lifeline type screenings and other such things. I think that you have to kind of take the global situation in hand, a person's age, gender, family history, medications, medical history, and other such things when giving them advice. And there's a difference between evaluating someone who's had a stroke, which is they have had a disease, that would be a diagnostic test, versus a screening test, which is what we're talking about here. You're looking at people without symptoms to evaluate whether you can detect disease and do something about it before it causes them a problem. So they are very different things.
Somebody had mentioned that they have a score that would rank as severe in a family history. And they're concerned about what, it's not the score is not good, but might be a function of the type of plaque, hard or soft, in terms of underlying risk. So
right. Score only sees the hard plaque, right? Only
right, hard plaque. Okay. Is there a more aggressive treatment option than the conventional treatments that you recommend to a high risk patient?
So there are the first line of therapy is statins. So rosuvastatin, atorvastatin, the cholesterol lowering medicine, in addition to aspirin, if you fall into that group. Then you try and get a target LDL. Most people would say try and get that LDL cholesterol down less than 70. And so statins alone may do that. But if they don't, there's something else called ezetimibe or Zetia that can be added to a statin to lower cholesterol further. And then there's something called bempedoic acid, which is another one. It's a pill tablet that can be given. And then specifically for people with super high cholesterol and a lot of plaque, there are injectable medications called PCSK9 inhibitors like Repatha or Praluent that lower cholesterol by a different mechanism. And then finally, there's something called inclisiran, which is a relatively new one, which is a small interfering RNA particle that works in a different way still to reduce cholesterol. And that's given by injection after 2 doses about a month or so apart on an every 6-month basis and lowers cholesterol. But that one, because it's so new, doesn't have a lot of what's called outcomes data. In other words, all the other medications I've listed are shown to reduce heart attacks and strokes. The newer medication, inclisiran, reduces cholesterol, but we haven't had it around long enough to be able to say it makes that difference. So, but there is a kind of a stepwise fashion of addition of medications to help to get to that target and reduce a person's risk.
Okay, great. People are starting to ask specifics about all their numbers. We can't address all of those things. Would take forever, but
well,
I
my
do
address
have
is right there. So
right, there is the like
down.
oh, that's so kind. Yes, there is. Yes, please call or make an appointment. These are great questions. Additionally, somebody just mentioned that they did have the test, as I've done. It's very simple, very easy, and I, highly recommend it. And insurance is an issue for some, but it is a manageable. It is affordable, and some insurances do cover it. I do want to say that as well. Thank you so much, Dr. Murphy. It was just a great presentation, so interesting and so much information.